This is the phase 1/2 trial, so I don't bore you with that, but it's just to make the point that it's really complicated because it has both single-agent asciminib and a number of combinations with dasatinib and nilotinib and imatinib, and this trial is still ongoing. Response rates, as reported at the 2016 ASH meeting, and adverse events show a very good profile. The dose-limiting toxicity at this point is lipase elevation, and this is also the most frequent significant toxicity. Otherwise, this agent is pretty well tolerated. This is response, and it's what you look here is basically people with an accessible level of resistance. So people in CHR will have about 85% ability to achieve with hematologically active disease, have an 85% CHR rate. Same analysis for CCYR at about 70%, and then there's also molecular improvement. So I think all in all, a significant level of activity. With T315I, again, there is responses maybe a little lower than in other genotypes, but the study is ongoing, and it'll be interesting to see what happens at higher dose levels. Just to mention a few other inhibitors that are either in development or approved. Redotinib is essentially an nilotinib analogon with a very, very little change here. It's approved in Korea. KO706 is another inhibitor with activity against T315I. It's currently in clinical trials. Structure hasn't been published. Axitinib is a VEGF inhibitor approved for renal cell cancer that has a very surgical activity against T315I only. So there are a couple of case reports that show activity, but we currently think it may be not broad enough to really be widely applied. And then lastly, there is a compound called PF114 that is, again, very similar to another inhibitor, in this case ponatinib, with a single change here. This compound has activity against T315I. It may be more specific and less toxic, and is currently in phase 1 trial in the Russian Federation. So this is my little idea of how CML works. In the chronic phase, the disease is highly BCR-ABL dependent, and fortunately, this is also where most of the clinically relevant disease sits, and so it's very well treatable with TKIs. The key question really is how far can we get with that? This is a comparison that is really not statistically allowed, but it just shows you the response rate of the abandoned EPIC trial on ponatinib in the front line in comparison with the NSTIN-D study. And we look at molecular responses here. This is ponatinib, and you see there's a really high rate of early and deep molecular responses. And this is in comparison what you see with nilotinib. So you could say that ponatinib is maybe the best we can do with BCR-ABL inhibition just in its own right, and kind of provides some benchmarking here. Unfortunately, this is also very toxic and not currently approved for the front line. It may never be approved for the front line. So that brings me to the question of vascular toxicity. This is a meta-analysis of vascular toxicity on second-generation TKIs in comparison with imatinib. And you see all the bars are over here, indicating that all second-generation TKIs and ponatinib have increased cardiovascular toxicity. And so we need to balance that versus I think the drive to use these agents in the front line in the hope of achieving a deep response and then finally putting discontinuation of all TKIs. Now, I think thinking is that while these vascular toxicities are probably off target, and I think there is really all reason to suspect that these are vascular system kinases, and you see the various TKIs listed here have quite a bit of activity, including bosutinib, dasatinib, and particularly ponatinib. But there are other TKIs, such as VEGF inhibitors, sorafenib and sunitinib, that also hit a lot of these kinases and have a strong association with hypertension, but not with vascular toxicity in the sense we see that, for example, with nilotinib. So what I want to put forward is that I think the jury is still out whether the vascular toxicity might actually be on target. This is data that I already alluded to. This is ABL001 or asciminib. If you combine that with nilotinib, you are able to essentially suppress resistant clones altogether. And so we are able to achieve a very, very high level of ABL inhibition. But the key question is really whether this will gain us a therapeutic window that we don't otherwise have. This is retinal vessels grown in the presence and absence of imatinib, and you clearly see that there is quite a bit of pathology over here. So the ultimate question is, the ultimate limitation of ABL-targeted therapy may be vascular toxicity, if that proves indeed to be on target. So in summary, this armamentarium of TKIs is surprisingly still increasing. ABL-T59 is resistant to second and first generation TKIs, will probably have another really good option in the case of asciminib, and I really continue to be concerned about the cardiovascular risk, and that needs to be balanced as we tailor treatment to our patients. Thank you very much.